It's very safe. Mortality is like what, 0.1%. This is lower than doing delivery. People deliver baby also mortality is higher.
Welcome to our first Baria Talk, where we talk about all things bariatric surgery. I'm your host, Neeta, and today we're taking a deep dive into the most commonly performed bariatric surgery worldwide, sleeve gastrectomy. Joining us is Dr. Navin Mann, a bariatric surgeon in Kuala Lumpur. Dr. Navin has performed hundreds of bariatric surgeries in the past year alone and has helped countless Malaysians transform their health through surgical weight loss. Dr. Navin, welcome to the show.
Hi, thanks for having me.
So let's start right at the beginning. For someone hearing this term for the first time, what exactly is sleeve gastrectomy?
Okay, so you see, before we talk about sleeve gastrectomy, we need to talk about what we are trying to achieve here, you see. So this obesity, this disease obesity, this is a terrible disease to have. It's growing, it's getting out of control in especially this part of the world, especially in Malaysia. So you look at the population, a very significant amount, I think about 40% of people are already obese in Malaysia. So now in today's world, obesity is not something you have to live with.
Mm-hmm.
You see, we can do something about it. Like you know how the world advances in healthcare, in cancer treatment. Previously, you got cancer, you will die. Now you don't, right? Now you can live. All sorts of modern treatment. So same thing for obesity. We got treatment for you. We can treat your problem. This obesity is a metabolic disease. It's not going to go away. Okay, so you can try whatever you want. You try to diet will just when you restrict, we look about diet. When you restrict, you just limit your calorie intake. So when you limit, of course, your body will start getting calories from first thing it does is burning down fat, followed by muscle. So but the minute you start eating again, then your weight is just going to, the whole thing will happen again. Your weight will start going up. So to solve this problem, the gold standard today is still bariatric surgery. There are other, I call them adjuncts, medications like all this Saxenda and all. They are adjuncts to surgery because they don't give you good, sustainable results. Okay, so now the most commonly performed surgery is sleeve gastrectomy. That's true. It was started a long time ago, somewhere in 1993. Initially, it was part of another surgery, the BPD. Then people started gaining recognition as a standalone procedure.
Sorry, doctor. What is BBD exactly?
It's another old bariatric procedure below pancreatic deviation. It's something like the newer bypasses we have. There are many bariatric surgeries. People don't just think bariatric surgery is one procedure. There's a lot. It's evolved over the years. As we learn more, and we evolve more. So sleeve was part of one of the earlier surgeries. Then we start seeing results of sleeve. Very good results. Easy to do, simple, fast, good results. And then people adopt as a sleeve as a standalone procedure. Okay. So in sleeve gastrectomy, as the name suggests, we operate on the stomach and make it like a sleeve. It's shaped similar to a sleeve. Around a bougie, we use a calibration tube of varying sizes. Different places use different size. But the idea is to tubularize the stomach. So we remove about 75-80% of the stomach. Now, which part we remove also is important. So we have to meticulously curate the sleeve properly. So it's not easy to just do a sleeve. There are a lot of technical aspects to doing a good sleeve. So we have to remove the fundus in the body. Why? Because that's where we get the hormonal effect. I'll explain that later. So it can be done in about 35 minutes, 40 minutes or so. It's quite fast. And for that reason, it's very popular.
Right. That's fascinating. So what we understand as well, that it is not only about how much your body eats, but it also apparently changes the way your body feels hunger. Is this true?
Yes. Yep, that's true. So you see how it works. You see, the beauty of bariatric surgery is it doesn't work on a single pathway or single effect. It's multimodal. There are various ways how the surgery works. Previously, in the past, it's like serendipity. Previously, people, when it was invented, the idea was to restrict. That means make your stomach smaller, eat less, lose weight. Simple. right? And then we realized over time, things like diabetes were going into remission, hypertension going into remission. And why? So when you look at the hormone levels in these patients, ghrelin, leptin, GLP-1, and all these intestinal hormones, they tend to change after bariatric surgery, right? So that's when we start realizing there is a very strong neurohormonal component to bariatric surgery. And that's how we call it metabolic surgery, because it gives you a very strong metabolic effect. So like sleeve is not primarily a very good metabolic surgery, but it has some metabolic effects. You see, one of the hormones in the stomach, it's called ghrelin. Now, ghrelin is oxyrigenic. It's called oxyrigenic. It induces appetite. Okay, that's how your stomach talks to your brain via these hormones. So the stomach secretes this hormone, it talks to your brain and in the hypothalamus. That's how you feel hungry, right? So when you do sleeve, we remove the part of the stomach that's responsible for secreting that hormone. A lot of the hormone comes from that area, the fundus, about 65%, 70%. So when that hormone comes out, obviously your hunger is going to drop. The cravings, grazing habits, all this will drop. So the amount you eat will drop. Okay, that's only one. Now there are other hormonal effects of sleeve as well. It's modulated via GLP-1, and these are the hormones that come from your gut, your intestines. There are different types of cells in there, L cells and all. So they secrete GLP-1, PYY, GIP. These are hormones that regulate your metabolism, basically. Right. So that's how you get a very good result after doing a sleeve. Now that is the hormonal part. The other part of sleeve is when you just eat less. So when we do a sleeve, the stomach is calibrated to about 39. I do at 39 French, which is about 1.3 centimeters. So it's really small, like that only.
There are a few. There are a few variations.
Different people do it differently.
Right.
But generally, it's around there. Okay, so the reason why I use 39 is because I noticed, and if you look at the research, the risk of forming a stricture is quite low. Stricture is meaning sometimes when you do surgery on any hollow organ, esophagus, stomach, intestine, anywhere, one of the complications is forming stricture. That means a scar tissue and making the organ too narrow. Too narrow means it like sort of close up and the food cannot pass through. So with this size, the risk of stricture is very low. So far, we have not had any strictures. So it's calibrated to that size. Now, that size, you can't eat much. You eat very little, 3 or 4 spoons, that's it. So part of the treatment, we will teach you what that 3 or 4 spoons should be. It shouldn't be, just eating anything off the rack. So there's the certain diet protocols you need to follow. Okay, so that's the restrictive component. See, there's a restrictive component of sleep. So together, in concert, all these things act together. This gives you your result, your weight loss. And not only weight loss, remission of comorbidity. That means the diseases literally go away. Diabetes, hypertension, cholesterol.
Which brings me to the next question, doctor. Who is a good candidate for bariatric surgery, in particular sleeve gastrectomy?
Okay, so there are guidelines out there. It's all available everywhere online. So, but for me, if you have obesity, you need to be treated one way or the other. So then we talk about treatment. So sometimes we do medication, sometimes we do gastric balloon, sometimes we do bariatric surgery. But by and large, I will tell you, if you want something sustainable, something to solve your problem, a good solution, of course, is bariatric surgery. Now, generally, you need to, for Malaysians, the cutoff is about 27.5 with obesity-related problems. So you need to have diabetes or some problem pertaining to obesity, and then you qualify after that. Okay, but that's not hard and fast. Sometimes people have problems, they have issues. Their baseline weight is so low, and suddenly they regain, and then suddenly 27.4 with diabetes and all. So are we going to say no? So it's not rigid, right? That's why the clinician have to decide, is this patient going to benefit or not? If the patient is going to benefit and has a genuine problem, then yes, they can do bariatric surgery.
Can you walk us through what actually happens during surgery? How long does it take and what's the recovery like?
Okay, so now pertaining to sleeve gastrectomy alone, what we'll do is, first when you come in, of course, I will screen you, right? I will talk to you, I will screen you, and I will decide what do you need. Do you need surgery? Do you need gastric balloon? Do you need medications? So once we have decided what you need to do, I will talk to you about your options. There are always options, risk, benefit. So we look at patient's problem and also patient's expectation. We got to see what is the patient's expectation. What do you want from this? Some people with diabetes taking, maybe 4 or 5 different medications, high insulin dose. Those patients need a bypass actually. But they will tell you, I'm okay with still having to take 1 or 2 tablets. I'm okay with that.
Right.
I just want a sleeve. I don't want to take the risks of going through a bypass. Bypass has its own set of complications, although they are low, but they're still there. So some patients are not happy to endure that risk. So the patient expectation is important. The patient problem, patient expectation. So when we decide to do a sleeve, then I will teach you, or my dietitian will teach you your diet. You need to do a diet first,
Right.
a VLCD diet. Okay. So basically, we are trying to induce a process called ketosis in your body before you come for surgery. So this diet is simple. It's just the idea is we are going to restrict your calorie intake. So your body starts breaking down fat. It's short. It's only about 14 days, 10 to 14 days. So in the 10 to 14 days, your body is not going to go and break on muscle. The first thing it does is break down fat. So we want that before surgery. Your liver will shrink by 30%. Fatty liver is very common in obesity. People have cholesterol, they have fatty liver. Liver becomes big, huge, heavy. So the stomach is below the liver, right? So when you shrink the liver, the surgery becomes easier, faster, less complicated. So there's a lot of benefits of doing this VLCD. Even after surgery, the first 1 week, you will put on a liquid diet, only liquids. So there's a certain type of drink that you will prescribe for you to drink. It contains all the nutrition that you need, right? So the same drink we will use before surgery, during your VLCD. So now you're used to it. So after surgery, to transition in the post-op time, you're familiar with the drink. So it's easy. I see patients don't struggle with the liquid diet at all. Completely, they're fine. Okay, so these are all the benefits of doing the VLCD. So once we teach you this, you go back and do that. Then when you come, in between, you will do your pre-op. Pre-op is just routine blood tests, X-ray, ECG. Or if you need any additional tests, if you have heart problems, kidney problems, lung problems, whatever they may be, I will need to order certain other tests. But that's very uncommon, usually just basic pre-op. Then when you come on the day of surgery, you need to fast at home. That means you don't eat or drink anything after 12. The whole day before surgery, you only liquids, okay? Because we want the stomach to be empty. And then morning we do surgery. Now, all this is done laparoscopically. Laparoscopically means, laparoscopic is an approach. It's how we're going to get into your stomach. How we're going to operate. You can do open, laparoscopic, robotic. These are all approaches. So laparoscopic meaning we just make tiny holes, and we put in pots and instruments and a camera, and we operate from outside. So we don't literally put our hands inside, right? So the wounds are very small. The recovery is very fast. We don't cut any muscle. Remember, when you do conventional surgery, the main source of pain is from the wound. It's when they cut muscle. So when we do laparoscopic, I use bladeless trocars. So my trocars don't even cut the muscle. They just split and go in. When you remove, the muscle will close back. So after surgery, once you wake up, anesthesia will take about maybe 3-4 hours to wear off. After that, you're up and about. You can walk, you can have your shower, and you'll be on your feet. And then the next morning, we will brief you on your post-op care, post-op diet, and what the do's and don'ts, and then you can go back after that.
Right.
So it's quite fast recovery. Now, even a lot of people like to ask me, they use this word called downtime. This term called downtime. What is downtime? I always ask them. Apparently, it means how fast you get to go back to your daily life. So it all depends what is your daily life. If you are just sitting at the desk and doing desk job, right? Then the 3rd day or 4th day, you can go back. No problem. The only difference is your diet. So you cannot go to cafeteria during your lunch break. You bring your drink with you. Okay? If your job is you have to climb electric poles and all these very vigorous duties, then of course you just take a bit more time to rest at home.
Okay, doctor, as you mentioned just now about expectation, could you just let us know what are the results like for someone who have just undergone a sleeve gastrectomy?
Okay, yeah. Now, what to expect, right?
Yes.
After sleeve gastrectomy, you're obviously going to lose weight, right? So what will happen is generally what we work on is excess weight. A lot of people like to compare. He lost 20 kilo, I lost 50 kilo, this one lost. You cannot count like that because different patients are different. Their baseline weight or ideal body weight is different. So what we do is we look at excess weight. Excess weight means the amount of weight you are above your ideal weight. Simple as that. So your current weight, deduct your ideal weight. So that's the excess weight. So generally, you are supposed to lose about 65 to 70% of that excess weight at about 1 year after sleeve. Generally, that's the target. So slowly you will get there over time. So now the graph will drop, okay? So it will drop very steeply in the first few months, and then towards 11, 12 months, it will start to plateau off. Okay, there are some reports you can see weight loss can go on till 18 months. Okay, but generally it's around there. So that we will set targets for you, and then this is what you have to work towards. Now, bariatric surgery is not something that can stand alone, i.e., you do bariatric surgery and then you're going to become thin the next day. It's a lifestyle, it's a process, it's like a reset button. We will bring you back to your good health, but we need your cooperation. You need to abide by the rules, the guidelines we give you, what to eat, what not to eat. The most important is what to eat, what not to eat. And of course, the next one is your exercises. And the third one is your multivitamins, your vitamins. We will tell you what to do. So you don't go into, deficiencies later. Okay. So the diet is simple because the appetite is very low. It's very suppressed. So when you eat maybe 3 or 4 spoons, you're already full. So you need to control what is in that 3 or 4 spoons. Okay. Right. And, after that, you just go on with your lifestyle. You should trust the process. The process will take place, and just trust the process.
Yeah. And what are the common concerns or misconception that you usually hear about?
So the most common misconception per se is people comparing one another. You shouldn't compare. So, they like to see their weight loss, your weight loss more than mine more than yours. Now, I notice patients tell me they form groups on social media or WhatsApp, Telegram, all this, and then they talk about, each other, your experience, Mike. That's good, but don't compare. If you want to compare, you need to compare your excess weight that you lose, percentage of excess weight. So, easy. Just take your current weight, pre-op weight, minus your ideal weight. Now that's excess weight, and how much you have lost, you just divide by that weight times 100. So you get your percentage of excess weight. So that's what you need to look at and monitor. So the reasons why these things, this excess weight does not go down as planned, the most common cause is actually the diet. Okay, so you really need to comply with the diet. So we have a 24-hour available consultation, case manager and dietitian who will address all these problems. Yeah, if you're not losing weight as per plan, then you let us know. We will explore. You can come in and we will look at it. And more often than not, we'd find out it's basically the diet. The problem is the choices of food. Okay. It's very difficult in Malaysia to comply actually, because if you're the kind that always goes out and eat, right, it's very difficult. There's hardly anything out there that is healthy. Everything is fried, sugar. These are the two big problems in Malaysia. One is sugar, one is oil, fat. So this diet is one of the misconceptions. Now, other things, people like to say bariatric surgery, risiko tinggi, very high risk. Not only among patients, among some doctors also. They're scared to don't do bariatric surgery because high risk. Now, if you look at bariatric surgery, if done properly, the risk is very low. There are things to look out for. That the ways to do bariatric surgery, you cannot just walk in, to the doctor's office and say, okay, admit me now to do bariatric surgery. It's not like that. So there's a process. There's a prehabilitation, there's DVT prophylaxis, nutrition, all these things you do properly. Follow the proper guideline. I was trained in a place in India, and it's a accredited center of excellence. So that center follows very, very specific protocols set by international guidelines. So we learn all these things. You do it properly. It's very safe. Mortality is like 0.1%. This is lower than doing delivery. People deliver baby, so mortality is higher. So it's very safe. There's nothing to worry about in that sense, in terms of safety, provided it's done by somebody who is familiar and knows how to do it properly. Yeah, I think those are the common misconceptions.
Right. Have you ever experienced any unique experience when it comes to, bariatric surgery? Any unique experience you'd like to share?
Unique, weird experience?
Yeah, unique, weird experience.
There are many actually. If you look at people, right, human beings are plenty funny. There was one patient, I will tell you, who called in and was not happy with his weight loss. He was not happy. He's an international patient. So I spoke to him and I told him his weight loss is okay, but it's just below what it should be. I tried to explore. What we do is something called a diet recall. So that's how we find out what what you're doing wrong, or we give you some time to do a food diary and come back to us after 2 or 3 weeks. So his diet seemed fine from what he told us. All this is based on what patient tells you. You cannot go back and monitor him 24/7, right? So he said his weight loss is not good, but the diet, what he told me, sounded okay. That's fine. So we just gave him some advice pointers here and there and follow up. I was considering starting second line treatment with usually when they don't reach their targets, we can use medication. I was considering that. But then when he finished the call, my nurse was giving him the advices on WhatsApp. And on his WhatsApp, you can see his WhatsApp now. You got a profile,
The status.
And the video. He's eating chendol durian.
Chendol durian.
Chendol with durian. Chendol is full of sugar with durian, very high carbohydrate intake, and he's eating that, and it's on WhatsApp. You see, so that he don't tell you, right? So this guy is a type of person who wants results but does not want to follow or comply with what he needs to do. You see, so there are people are a bit weird in that sense.
They have to be very forthcoming with.
Yeah. Many times you will find they're not very forthcoming. They tell you things that are not very true. But that was a bit of a thing. So we just told him, look, we noticed this, and I think you need to work on that. Then after that, he was fine.
So the final question that I have for you, for anyone out there who is considering weight loss surgery, do you have any advices for them?
Yeah. Okay. Like I think I spoke about this when I started. Obesity is very rampant. Okay. It brings about a lot of non-communicable diseases, diabetes, hypertension, stroke. Now, when you have 2 out of 3 of this plus obesity, you're already known as a patient with metabolic syndrome. A lot of people don't even know what's metabolic syndrome. Metabolic syndrome is when you have this metabolic disease and obesity. Now, when you have metabolic syndrome, you're already in a group of people who are high risk. Even if you look at the research, upon diagnosis, 50% of patients with metabolic syndrome already have a certain degree of coronary artery disease, meaning the arteries in the heart are already diseased, already blocked to a certain degree. So the process has started.
50%?
Yeah, up to 50%. Wow. It's very high. So you see, this obesity alone is not about being fat. It brings you a lot of other problems. And when you have this metabolic disease, stroke, heart attack, sleep apnea, kidney failure, dialysis, amputations, and various other problems come with it. So in today's world, you don't have to live with it. You don't have to go on living your life as an obese person. We can treat it. We can do something about it. The world has changed a lot. Medical treatments have advanced a lot over the years. So we can treat it. So please do come in for a consultation. We will explain to you. You see, it's not about just being fat. There's a lot more to it that needs to be treated.
Beautifully said, Dr. Navin. Thank you so much for joining us at Baria Talk. Thank you.